do that announcement.
Sure.
Good afternoon, friends, and welcome to this prestigious award oration, Tilak Venkobarao oration. And I'm really proud and privileged to be here as a chairperson of this session, and I'm really lucky to have Professor Mohan Isaac as a co-chairperson with me. There is a small announcement before we start. At 12:10, the lights will go off for 43 seconds. You have to rise for a national anthem. The occasion is, today is the 123rd birthday anniversary of Dr. Shri Netaji Subhash Chandra Bose. And everybody knows who Subhash Chandra Bose was, and we have to just rise up for national anthem, and everything will be off for 43 seconds, even the presentation. With this, I'll hand over to Mohan Isaac to say a few words about this award.
Good afternoon. We are sorry we are starting a little late. There were some problems in getting the PowerPoint onto the screen, etc. Now, we just finished the DLN Murthy oration where Professor T.S.S. Rao gave his oration on the Dart syndrome. That is one of the very prestigious oration awards of the Indian Psychiatric Society. If that was the most prestigious, I would say the second most prestigious oration of the Indian Psychiatric Society, which is given for a young person, is a Tilak Venkobarao oration. It's named after Tilak Venkobarao, who is a son of the late Professor Venkobarao. Just now? He said 43? Okay. Third birth anniversary.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Yes, we can sit and we'll continue. So this oration is named after Tilak, the son of the late Professor Venkobarao. Professor Venkobarao needs no introduction. He is a distinguished past president of the Indian Psychiatric Society, a past editor of the Indian Journal of Psychiatry, who, when he was at the prime of his professorial career, lost his son Tilak in an untimely road traffic accident, and then immediately to continue the memory of his son, he instituted in the Indian Psychiatric Society the Tilak Venkobarao Oration Award for a bright young psychiatrist of the Indian Psychiatric Society. So this year it is won by Dr. Urvansh Mehta, who is one of the very bright young research psychiatrists, academic psychiatrists of our country. He is currently an associate professor of psychiatry at the National Institute of Mental Health and Neurosciences in Bangalore. I would extend my hearty congratulations to you, Urvansh, and I would now invite you to deliver your oration on the topic, the social neuroscience of psychosis, from neurobiology to neurotherapeutics. Over to Urvansh for your presentation.
Thank you very much, sir. A very good afternoon to everybody. This is indeed an honor. I thank the selection committee to have given me this opportunity, and I am truly excited to share our work on the social neuroscience of psychosis over the last 12 years. So I will outline the presentation. I will initially start with what I want to tell you about how we can understand psychosis from the lens of social neurosciences. This will be followed by what is social cognition and its clinical relevance to psychotic disorders, the neurobiology of social cognition and psychiatric disorders, and what does this inform us in terms of improving therapy or treatment avenues for our patients with psychotic disorders, and we'll conclude with a summary. So to begin with, the first part of this talk is on social neuroscience and how that can be used as a perspective to look at psychotic disorders. This begins with some insights on social evolution. So how does the social brain get shaped over the course of years, and what makes us human? And that is typically ingrained into, it should be ingrained into our understanding about psychotic disorders. So when we say psychosis, to operationalize psychotic disorders, let me take three quintessential syndromes: depression, mania, and schizophrenia. These are clinical syndromes that we come across. There are core symptoms and there are additional symptoms, and as you can see, there are distinct core phenomena, but there is a lot of overlap, and we have acknowledged that, and we still go on with our diagnostic systems for practical purposes, but there is a common thread. And that common thread is that across depression, mania, and schizophrenia, there are social cognition and self-monitoring deficits. These social cognition deficits relate to social functional disability and social behavioral problems. So there is this link which is shared across all these three major psychotic disorders. Now, phenomenologically, we have identified a link, but there is also evidence from large-scale genetic studies. This is from the Brain Consortium, which was published a couple of years back, which states that depression, schizophrenia, neuroticism, ADHD, they all share the genetic vulnerability. So there is a shared genetic vulnerability which is distinct from neurological disorders. On the other hand, this slide from the BSNP consortium in the US shows how if you pool patients with schizophrenia, psychotic bipolar disorder, and schizoaffective disorder, better than their symptoms, there are certain neurophysiological signatures which come from EEG and neurocognitive studies, which categorize patients into type 1, type 2, and type 3. So there is a shared neurophysiology, there is a shared genetic mechanism. So that brings us to the question, how does human evolution inform our understanding of psychotic disorders? And I would like to start by quoting George Bernard Shaw, who said, "Reasonable people adapt themselves to the world. Unreasonable people attempt to adapt the world to themselves. And all progress, therefore, depends on unreasonable people." So in other words, there is a strong message coming out that you need to have some deviances in order to push progress. And a related concept which was put forth by Jonathan Burns was that psychosis and psychotic disorders are actually a costly trade-off in the evolution of complex social cognition. So this is an important lens through which we need to look at social cognition and psychotic disorders. So let us look at an example. So I will start by taking risk-taking behavior, which not necessarily is always your social cognition trait. And if you look at fitness is how well you transmit your genes to your offspring. So if you plot them on the X and Y axis, you will get extremes. You will get species or animals or individuals within a species who are high risk taking and low risk taking. And we know that over time, the natural selection that happens is against these two extremes. So very high risk taking behavior individuals will not have that much fitness, and very low risk-taking behaviors also will not have. You can imagine a rabbit who's trying to hunt for some food and goes near the tiger, and it is likely to be killed. And if it does not go out at all, it is likely to die by starvation. So what happens is those individuals with a median or an average risk-taking behavior, they get stabilized, and the others, the extremes, die out. However, this typical form of natural selection may not happen in all complex traits. Mentalizing, or the ability to infer mental states of others, that is also called having a theory of what the other person is thinking, or theory of mind, is a core social cognition domain. And this may have a different selection pattern. And this perhaps also shapes how we have differentiated from our great ape ancestors over the last 6 million years. So this theory says that as your social cognition genes increase, your fitness improves. So the more adept you are at understanding the other person's thoughts and intentions, you are better likely to transmit your own genes for fitness. But that comes with a cost, because if it crosses a tipping point or a threshold which is called a cliff edge, then there is a likelihood that you enter into some schizotypy, and if it further increases, then you have a risk for schizophrenia. So it is not that more is the merrier. We have to think again, and this is called the cliff edge model of how social cognition genes can be useful, so they survive in the gene pool, but they are also detrimental if it becomes excess, then that causes problems. And this is based on the principle of antagonistic pleiotropy, which is best understood by this. Genes that cause diseases in later life are naturally selected because of the advantages that they confer in early life. For example, you take amyloid plaques in Alzheimer's disease, they actually protect against gut infection during childhood. So they serve some purpose in early life. Uric acid crystals have anti-aging properties. There are many examples from the animal world. Racehorses are bred to make their legs long so that they run fast. But that comes with a trade-off that they are more susceptible to develop fractures. And we all know what happens to racehorses when they develop fractures. So they don't progress any further. So they are put to sleep. So this is an example. There are many such examples of antagonistic pleiotropy. And psychosis is perhaps something related to that it is a trade-off in the evolution of complex social cognition. So having given this perspective, we have identified this trajectory, and I call it the social connectome. It starts with the genes and the environmental factors that shape our brain. And we now know, and I'll show you how, that the brain has distinct social brain regions and non-social brain regions. And the social brain regions then predict social cognition, your ability to infer thoughts and emotions in others. And this social cognition then determines social behavior. And social behavior is finally related to real-world functioning, how you interact with your family, how you share relationship with your friends, your social circle, your occupation, etc. So this is also an important chain at which you can decide where you can intervene. You can have different targets of interventions at different points. So the work that we have done, and which I will be presenting, is on the social cognition and social brain, and some very, very preliminary treatment-related studies. So now this brings us to it brings us to the question, what is social cognition? The social cognition in the simplest sense is your ability to apply your cognitive processes to social interactions. And these are certain examples with which we encounter social cognition in day-to-day life. The first image on the left, can anyone say what do you see there? On the left top image? Yeah, so some of you see it as a dodo or a bird, and some of you see it as a rabbit. So it depends on where you look at it from. So this is a very classic example of how the same stimulus, sensory stimulus, can vary in its interpretation based on your own perspective. So it is to say that you have an independent perspective thinking, which the other person does not share, and the awareness that that system of thinking exists is very important. Otherwise, you'll end up having fights. The second image at the bottom, this painting, what is happening here? There's a card game. This is a very ancient medieval age painting. There's a card game going on. The man at the bottom is trying to cheat. He's hiding cards at the back of his belt, and the lady on the far right is actually seeing what he's doing. So he's trying to deceive and cheat, and she's trying to detect that deception or cheating. So your ability to deceive and your ability to detect deception requires theory of mind. So that is again another area of day-to-day living where social cognition applies. Of course, committing social blunders or identifying social blunders or faux pas. Imitation is a very important social skill which is perhaps ingrained, it is hardwired right from neonatal life. So these are certain real-world settings, and I'll briefly touch upon some of these in our experiments. So this brings us to the question, are we actually hardwired for social information processing? And I'll quickly take you through this video. Some of you would have seen this video. It is called the Hyder-Simil demonstration. What you would see is it's playing. Yeah. What you would see is three shapes. There is a big triangle. There is a small triangle and a small circle. The big triangle and the small triangle seem to be at loggerheads. The big triangle is intimidating the small triangle. The circle is perhaps afraid. She's trying to hide in the room. The small triangle is trying to fight, but the big triangle is perhaps stronger and he's shooing away the small triangle. The circle is trying to help, but she's also scared. She closes the door from inside. Now what is happening? The big triangle is entering the room. He closes the door. The circle is hiding in a corner. The small triangle is trying to help. Circle is trying to escape. And now what? So the circle has escaped, and circle and the small triangle are happy. They are celebrating. They are running away. The big triangle is searching where they have gone. He's looking into the room, and now they have disappeared. And now he's really furious. What is he going to do? The big triangle. He's going to break open the house. Yeah. So this is a very simple example of. It is called. So what I did was I actually led you into a story, and perhaps that is to save time. I could have shown that to you and asked your response what is happening, and you also would have given similar intentions, emotions, identities to inanimate shapes, two triangles and a circle. So this is called an illusion of perceptual animacy. So we see life in anything that moves. So this is called biological motion perception. It is a very salient trait that humans have. We tend to perceive life and intentions, emotions in even inanimate moving objects which move in random fashion. And it's actually a social illusion. This is a very culture-neutral paradigm to assess your mental state attribution or theory of mind, which has been used in the Human Connectome project. So these are various stimuli which are given. Some are without any intention, some are with intention, as you can see. Some are random, some are non-random. And they find that the superiotemporal sulcus in the posterior part, the posterior superiotemporal sulcus, is an area which drives or this understanding of biological motion perception. So this tells us that we have a very strong hardwired nature to understand socialness in even inanimate objects, leave alone in living objects, living people. So this now takes us to what our studies have been showing about the construct of cognition and social cognition in psychotic disorders. So just to deconstruct what are the different cognitive abilities, this is a smart mnemonic that you can use to remember what are the various cognitive domains. S is for speed of processing, M is for memory, A is attention and vigilance, R is reasoning, problem solving and other executive functions, and T is tact or social cognition. Now I have colored them differently because factor analytical studies have shown that the first four cluster together. They come together, that is the domain of neurocognition, and social cognition comes as a different, distinct dimension. And our studies have shown that first and second order theory of mind, which we call inferential abilities, is one factor. Socio-emotional abilities, to detect emotions in faces, to detect emotions in social interactions, that comes as a separate category. And the third category is that of attributional styles. So what causal attribution I give to some social event happening to me, any positive or negative event, I attribute it to myself or to another person or to a situation. So that is called attributional style. So there are these three distinct dimensions of social cognition. When we started out in 2007, this was an emerging area, and we understood that social cognition is definitely shaped by culture. And I'm sure all of you would agree. And it is not correct to borrow tests which are developed in the Western world to study our patients. So colleagues of mine and our group, we developed different sets of tests. So there is TRENDS, or the tool for recognition of emotions in neuropsychiatric disorders, developed by Dr. Rishikesh Behere, and there is Socrates, or social cognition rating tools in Indian setting, which we have used to assess the other dimensions of social cognition, namely theory of mind and social perception and attributional styles. So these use picture-based stories, questionnaires, videos, and static and dynamic images to assess the whole spectrum of social cognition. I will not go into the details, but a point to note is that over the last 12 years, there has been an increasing use of these social cognition batteries all across the country. Now, we have actually trained close to 50 researchers in India, which come from all these diverse institutions and states across the spectrum of mental health professionals who are interested in looking at social cognition in a broad range of psychiatric disorders. So coming to some of our earlier studies, we examined social cognition in schizophrenia, and we saw that they have a very strong magnitude of social cognition deficits, which go up to Cohen's D, or effect size, of almost 2. And this is across the board. Nearly all domains of social cognition show deficits, even after controlling for their neurocognitive deficits. And this is in remitted patients. So this tells us that it is perhaps a trait marker which is existing in patients with schizophrenia. Interestingly, in patients with bipolar disorder, we find that, as you can see here, the red circle, there one of the theory of mind abilities, second order theory of mind, is actually better than even healthy subjects. So patients with bipolar disorder have better theory of mind, but they have poor emotion recognition, even worse than schizophrenia. So this is from our studies in bipolar disorder. In borderline personality, we find that there is no impairment in theory of mind or emotion recognition, but their ability to detect social cues in social interactions, this biological motion perception, social rules, roles, that is impaired as compared to healthy controls. In dementia, early course, mild cognitive impairment and early Alzheimer's dementia, we find there are social cognition deficits, but when you control for their neurocognitive impairments, they don't stand. So it is a part and parcel of the general cognitive decline that is happening in dementia, which contributes to social cognition. So the question is whether we can look at even further early cause. We do a proper sampling of only mild cognitive impairment and look at that. In somatoform disorders, we find theory of mind impairments which relate to somatoform symptoms. It is also related to your emotional awareness, your alexithymia and emotional, so how you are able to apprise yourself. So I will talk about how understanding others' minds, it actually depends on how well you understand yourself. So you use your own understanding, your self-understanding, as a template to understand others. So that is going to come up, and this highlights that in somatoform disorders. In social anxiety, we find deficits in both complex socio-emotional domains like FOPA recognition, emotion recognition, as well as a self-defeating bias, an attributional bias. There is also, so the question then comes is, so what if patients with these psychiatric disorders have social cognition deficits? How does it matter? So what is its functional significance? And that is actually one of the thrust areas of research in psychotic disorders across the world, is to understand how symptoms and cognitive domains, especially social cognition, relate to poor functioning, and do they predict functional outcomes. And we also replicate findings from the Western culture, which shows that anywhere between 6 to 20% of the variance in functional disability is explained by cognitive deficits, which is mediated by amotivation, a negative symptom, and lack of insight. Now, since we are able to establish that cognitive deficits, social cognitive deficits are present in psychotic disorders with a differing spectrum of performance, and that it relates to functional outcomes, the next question that we tried to address was, does it relate to specific neural subsystems? So we went out looking for what neural system can explain these social cognition deficits. And these investigations have led us to certain interesting and conflicting findings, which I would talk about. And the most important neural system that we have studied is the mirror neuron system. Again, this is an example of what I have been telling so far, that our ability to understand others depends on how well you understand yourself. So now I will take you through some theory about how we understand or make sense of others. So if someone asks you what is he or she thinking, or what is going through his or her mind, we can try to infer that based on these three different processes. The first process is called theory, as in you have no idea about what is going on, but you just theorize that this person might be thinking this based on whatever information you see from his or her face. So that is a proposition that you make. It is a theory, it is a theoretical proposition that you make. And I'm sure you agree that it is not always correct. The next level is called a simulation theory, wherein you make a pretense. What if I was in her shoes and I think like him or her, and I simulate his mind and think from his perspective? So that is called pretense-based simulation theory. And the last part, where the relevance of mirror neurons, is called embodied simulation. Embodied simulation is a type of simulation, but here you don't do it cognitively, it happens spontaneously. It can potentially explain concepts ranging from aesthetic experience to intersubjectivity-based psychopathology in schizophrenia. The best way to understand embodied simulation is perhaps through this video. You are seeing, perhaps you can see the video and then we can discuss. All right. So what you see here is the young girl's dog, whom she is perhaps attached to, is receiving an injection, and she is holding her hip, and almost as if to say that it is paining her. So she has not gone and theorized that the dog might be feeling pain. She has not simulated because it needs time. It happens spontaneously. And that spontaneous simulation, which is body driven, it is perhaps related to your mirror neuron system. So the mirror neurons are a concept which came in the early 1990s, where a group of neurophysiologists in Italy identified these specialized neurons which are activated not only when you perform an action, but also when you observe someone else perform the same action. So the same set of neurons, your motor neurons are giving you a signal to go and pick up a mug. When you see someone else picking up the same mug or any other mug, the same motor neurons in your cortex are also activated. It is more in the premotor cortex than in the motor cortex. The ventral premotor cortex is a typical site where mirror neurons are present. So this opened up a lot of questions and theories, so much so that people went on to say that mirror neurons have shaped human civilization and so on and so forth. But let us be more practical and look at what the evidence says. So these are various regions in the brain, like the ventral premotor cortex, the inferior frontal gyrus, insula, the inferior parietal lobule. They are all regions in the brain which have these mirroring properties. For a long time, people were skeptical whether mirror neurons are present only in the monkeys, because that was where it was described at the beginning by Rizolati's group. But in 2010, Roy Mukamil and colleagues, they are neurosurgeons. They operate patients with epilepsy, refractory epilepsy, who are in observation with electrodes placed in their brain before the surgery. So at that time, they have done experiments and they have demonstrated through cortical electrical potentials that mirror neurons are present in humans. But obviously, you can't open up the brains and put electrodes in your patients to study mirror neurons. So what is the next best method? So we use something called transcranial magnetic stimulation. I'm sure all of you are aware that TMS is a treatment for depression and some other psychiatric disorders. But we use TMS pulses to study cortical potentials from the motor cortex. And that is an investigational utility of TMS. So we deliver TMS pulses to the left motor cortex. The pulse then transmits and activates your right hand, and that activation is visible as a twitch, and that twitch, the strength of that twitch is recorded as a motor evoked potential. So you can see the motor evoked potential here on the left side. When you are observing a static image, there is a particular amplitude of the motor twitch. However, when you are observing actions performed by that same muscle from where the recording is taking place, the amplitude of the twitch increases. And this increase in motor evoked potential, it is called motor cortical reactivity facilitation. So this facilitation of motor potentials is a measure, an indirect measure of the premotor mirror neuron activity. So because your mirror neurons are active while action observation, you can see that the motor potential size increases. So this difference in MEP size is an indication of indirectly showing us the premotor mirror neuron response. So in our earlier studies in schizophrenia, we demonstrated that untreated medication naive patients have a deficit in mirror neuron response. As you can see, the blue bars represent the MEPs during the rest condition, and the red bars represent the MEPs during action observation condition. During action observation, the bars are higher in the treated patients and healthy controls, but in the untreated patients, it is almost opposite. So this deficit in mirror neuron activity was related to their theory of mind performance. So we did tests of theory of mind using these picture-based stories, and there was a relationship across different measures of mirror neuron activity and theory of mind. So this tells us that they are related. So the diminished responsiveness of your mirror neuron system is perhaps related to your social cognition ability, especially theory of mind. We then used a contextual priming of the mirror neuron system, and where I will not go into the video in detail, but we give a context wherein the action observation is noticed, and that context then increases your mirror neuron response in both patients and controls, but less so in patients. So this was work done by Virupaksha and group in his MD thesis. So having understood that social cognition is related to poor mirror neuron responsiveness, we also tried to examine how is it related to your imitation behaviors. And that came across through this chance encounter with a patient. This lady presented to us with 3 days of not sleeping, being withdrawn socially, and she repeated verbatim whatever was spoken to her, which is called echolalia. And she had been depressed in the prior 1 year. So we looked at her mirror neuron system. We hypothesized that because she is having an automatic imitation, her mirror neuron activity would be high. And we found that there was a high mirror neuron activity before treatment, and 2 weeks after the treatment with lorazepam, her mirror neuron activity actually became flat. So this actually made us think that perhaps your hyper responsiveness is, or the echolalic behavior is because the mirror neurons which are under some regulatory control of the prefrontal cortex, that regulatory control is lost, and that results in an exaggerated mirror neuron response, which then can result in echolalia and echopractic behaviors. Later on, we followed up that woman, and later, 3 months later, she had a hypomanic episode. So she actually had bipolar disorder. And that made us evaluate these echo phenomena in patients with mania. So we know that mania is a very typical state of disinhibition, and we hypothesize that they will also have echo phenomena. So we used this experiment where we would talk to the patient and record automatic or induced echolalia, and we would also talk to the patient's caregiver and see if the patient is echoing what we are talking when we are not addressing the patient. So that is called incidental or ambient echolalia. So what we found, out of 40 patients with mania, 17 had incidental echolalia, which is which was actually not surprising. We do see echolalia in patients with mania. These patients do not have catatonia. We did the same mirror neuron TMS experiment, and we found, to our surprise, that the mirror neuron activity in mania was actually high, and that related with their incidental or ambient echolalia. It also was associated with their symptom severity. So now we have two domains, or two ends of one spectrum: a diminished mirror neuron responsiveness and an exaggerated mirror neuron responsiveness in patients with schizophrenia and in patients with mania. They both relate to different domains of social behavior. One relates to a deficit in social cognition, and the other relates to a disinhibited social behavior like echolalia. Strangely, 10 of those 40 patients with mania, they completed a theory of mind task, and the heightened mirror neuron response did not predict better social cognition in them. It was related to poorer social cognition. So that means that an exaggerated mirror neuron system does not automatically translate to being a pro-social cognitive trait. So this then leads us to identify this mirror neuron system as a potential biomarker to differentiate patients with mania and schizophrenia. Not that you can not do that clinically, but you may sometimes encounter patients where there is a diagnostic dilemma, and this can be used, and healthy controls come in between. So with this culminates our current understanding. So what we postulate and theorize in one of the papers in schizophrenia research is that the genetic and environmental factors which shape our social brain make, and especially in psychosis, if there is a persistent symptoms which are long lasting, like negative symptoms, cognitive impairment, self-monitoring deficits, insight problems, they are all related to a diminished mirror neuron responsiveness, and sporadic or episodic increase in mirror neuron activity relates to catatonic symptoms, manic or affective instability, and perhaps auditory hallucinations, which comes from another group. We have not found an association, but there is a different group which has found an association between exaggerated mirror neuron responsiveness and hallucinations. So, with this, I will come to how does it matter in terms of treatment. There are various ways in which you can engage the social brain. You can engage the social brain by training people to imitate what you are doing. Imitation can be used as a social skill building exercise, and what better tool to use as an imitation exercise than exercise or yoga. So we have used yoga as a treatment for schizophrenia and found that as compared to waitlist, it improves their social cognition. We also assessed their mirror neuron responsiveness, but there was no difference in that, but it does improve social cognition, perhaps through a different mechanism. Giving brain stimulation or repetitive TMS to the mirror neuron regions and enhancing that has been demonstrated in one of our studies. Whether that, when given at successive intervals, changes social behavior or makes the individual more amenable to receive cognitive training, that is something which can be examined in future studies. So I will conclude by summarizing that there is a differential response of the mirror neuron system which is related to specific symptom dimensions of psychotic disorders. A reduced mirror neuron response is related to poorer social cognition, and an elevated, perhaps disinhibited mirror neuron system is related to greater echolalia and manic symptom severity, as well as poor social cognition in mania. It can be malleable, it can be changed by social contextual factors, by cortical regulatory factors as we have seen. And yoga, brain stimulation, intranasal oxytocin, these are newer therapeutic avenues which can have a potential impact on social cognition. So this is a summary slide which again comes back to the social connectome and identifies key treatments which can be given at different parts of this connectome structure. With this, I come to the end, and I again thank the organizers for giving this opportunity. I acknowledge all our patients who have been part of all these experiments, their family members for patiently being part of these experiments, all the research fellows, MD residents who have done all the work, my mentors at NIMHANS, at Beth Israel Deaconess Boston, and the funding agencies. Thank you very much.
No question. Thank you very much, Dr. Mehta. That was a very interesting presentation. I am sure many of you have various kinds of doubts and questions, but as is the tradition for this oration, there are no questions. But I'm sure Dr. Urvashi Mehta would be delighted to answer any of your questions off the stage after the session. This is, of course, for many of us, it may have been new. The potential of social cognition and various therapeutic implications has been highlighted. This has been an excellent body of work that he has been directing, as well as his group in NIMHANS has been doing. Thank you very much. Please give him a big hand, ladies and gentlemen. So this concludes the session, and thank you very much once again, Dr. Mehta.
I would like to request Dr. Mehta to honor our chairpersons, please.
I don't know. Oh. Yeah. That's why nothing. Good. Thank you.
I would like to request Dr. E. Mohan Das with our honorable chairpersons Dr. Ajit Awasthi and Dr. Gautam Saha.
Should we start? Well, very good afternoon, ladies and gentlemen. We have a very illustrious speaker for this particular session. He is Dr. E. Mohan Das. And as you all are aware, this session is a sponsored session by Sanofi. And I have the pleasure of being the chair of this session. It has been some kind of, you can call it distress or concern, that we psychiatrists are getting ourselves limited to only few topics for management or few illnesses for management in psychiatry. We are not giving as much attention to the care of the cognitively compromised elderly. We have almost given ourselves up on dementia. We are retreating ourselves from intellectual disabilities and other developmental disorders. And probably we are very happy just dealing with depression, mania, schizophrenia, anxiety disorders, and that about it. I'm very happy that the topic for today's talk by Dr. E. Mohan Das touches upon another aspect on which we had our own particular expertise at one point of time and our contribution as professionals, and that is the subject of epilepsy. And Dr. Mohan Das will focus on something which has been talked about since time immemorial, but nevertheless we seem to have lost our interest in it and are losing our skills to manage it, and that is the psychiatric comorbidities in epilepsy. It's my hope that through his talk we'll learn a lot about the psychiatric comorbidities and their interplay with epilepsy and how it poses a challenge for us to manage it. I won't say much at this stage because I will leave for Dr. E. Mohan Das in his inimitable style to bring out the various facets of the topic. But nevertheless, it's my pleasure at this time to introduce two people who are sitting on the right and left of my side. One whom I've treated like my elder brother, and he's Dr. E. Mohan Das. Who doesn't know E. Mohan Das in psychiatry? That's how I will start it. Well, he has been a pillar of strength for the Indian Psychiatric Society, been its past president also, but not only with Indian Psychiatry Society, but also he is associated as the chair or the president of so many other professional bodies related to mental health in India, like he has been the chair of the Indian Association of Biological Psychiatry, Indian Association of Private Psychiatry, Society for Bipolar Disorders India, and so on and so forth. I almost fell off my feet when I learned, in fact it was even more than my guess, that he has to his credit more than 1,000 scientific presentations. And that's an amazing feat. And not only that, he has won more than 25 awards, which includes 5 very outstanding international awards also. Incidentally, I've shared a very long professional association with Dr. E. Mohandas. Before he starts, it's also my pleasant duty to introduce the moderator and co-chair of this session, my younger brother, whom I have always regarded as my younger brother. So on one side is the elder brother, on the side is the younger brother, and he's Dr. Gautam Saha. And again, who doesn't know Gautam Saha in Indian psychiatry? So, like two illustrious people. He is the future of psychiatry in India. He's already, one of the most outstanding psychiatrists for his contribution to mental health. He is going to occupy very high offices, but he's currently the Vice President of South Federation of Psychiatrists. We are all here enjoying the hospitality and the comfort which he has provided to us as the Organizing Secretary of ANCIPS 2020. He is the immediate past Honorary General Secretary of Indian Psychiatric Society, a term which he held with aplomb and also a great efficiency. He is also the editor of the Indian Association of Private Psychiatry, and he is the Vice President cum President-elect of another very illustrious body, and that is the Indian Association for Geriatric Mental Health. He has a tremendous contribution otherwise too in academics and social aspects of the psychiatry, and it's my pleasure to welcome him to this session. With this, without much ado, I invite Dr. E. Mohandas to make us more knowledgeable regarding this almost forgotten topic in psychiatry, the psychiatric comorbidities in epilepsy. Dr. E. Mohandas.
Thank you, Chairperson. Dr. Ajit Awasthi, one of my dearest friend, and Gautam Saha. I don't know how to really describe Gautam. He is one among my family members. And seniors, my friends, I'm seeing some many familiar faces, seniors. Mohan Isaac is here. Most of the faces I can recognize. Now, psychiatric comorbidity, psychiatric aspects of epilepsy, as the chairperson has told that from time immemorial we know about it, but I will try to take back some of the history, then what is happening recently. Basically, the history beckons you, you know who is it. Hippocrates, he has told the melancholics ordinarily become epileptics and epileptics melancholics. What determines the preference is the direction the malady takes. If it bears upon the body, epilepsy, in the body, physicalistic epilepsy, if it bears upon the intelligence, it is melancholy. And many people talk about this history, about Hippocrates. Unfortunately, what is quoted in the history is a little bit wrong. The critical quotation was taken from the 6th book of Hippocratic work, Epidemics, section 8, paragraph 31. And a more precise citation would refer to the Greek-English edition by Smith. But unfortunately, the interpretation was wrong at the time. It was not the melancholia. The clinical picture seems to fit better with a dysthymic disorder or a chronic depression or a depressive personality disorder. And this has been beautifully put out in Epilepsy and Behavior Journal 2019. There's a criticism on the historical point. Some of the selected contributors in psychiatric aspects of epilepsy, many of you might be knowing, Trimble, you know, his books, and he is still kicking out even in his mid-80s, and frequently we meet. Then Kanner, you would have read many books. Marco Mula, he's on books on psychiatric aspects. Josephson, Natalie Jetty, and Bernardo Velli, and the Bragati from Spain. Salpeter, we have got somebody from Indian origin, but Salpeter, though he is Indian origin, he is not settled here, he is in the States. And Catherine Nichols and Coraline Kingray. The mediators of the neurobehavioral comorbidities of epilepsy may be because of the core epilepsy characteristics. It might depend upon the brain development and aging. It may be a translation of the underlying brain disorders or the epileptic syndrome. The neurobehavioral comorbidities encompass the cognitive, psychiatric, and social dimensions. There are some genotypical, psychological, and socio-cultural influences. If you want, the beautiful paper in Lancet in 2002, reasonably good article, readable. Now the comorbidities, the most common comorbidity is depression. Around 1/4 of the people will have depressive syndrome, 23.10, around 1/4. And 20 to 60% among those with uncontrolled epilepsy may not be completely a depressive syndrome, but depressive symptoms will be there. Interrectal depression is the most commonly reported, and dysthymia only 4%, and adjustment disorder with a depressed mood is 10%. Anxiety disorders, around 22.8%, psychosis 5 to 7%, but 7% basically in complex partial seizures, especially the temporal lobe, right? ADHD, especially children, around 20%, it may even go to the, you can stretch your statistics to up to 60%. Suicidality, 5 to 30%, but a big figure if you take it 12%. You can get obsessive symptoms and sometimes classical OCD, around 14% patients. You may get a manic symptoms as a manifestation, but maybe an underlying epilepsy, but you may mistake it as a mania, that is 12.2%. Personality disorder, very variable. A history of mood disorders preceding the onset of epilepsy, there is an increased risk for treatment-resistant epilepsy. Epilepsy and mood disorders have got a bidirectional relationship. A personal and family psychiatric history, an increased risk of non-psychiatric and psychiatric adverse effect to anti-epileptic drugs. This is from Kanner's article in Sheezer. Current and past history of mood and anxiety disorders may facilitate the development of seizures associated with stressful situation. That means it can incite it. There's a bidirectional relationship. A current mood and anxiety disorders is a strong predictor of poor quality of life. It is, self-understood. There are many instruments to assess depression in patients with epilepsy, meaning rational neuropsychiatric interview, meaning the SCID, you have got the CD, and another simple instrument is Neurological Disorders Depression Inventory for Epilepsy, NDDI-E. It has been translated into and validated in 14 languages, including our Hindi version, which was come in 2019. This is the scale. Everything is a struggle. You can rate it always or often, sometimes, rarely, never. And this is translated to Hindi in 2019, which was published in Epilepsy and Behavior Journal towards the end of I think September or December, Epilepsy and Behavior. Many of the anti-epileptic drugs can produce mood symptoms. It can be a mood stabilizer, but it can also produce mood symptoms, especially depression. Very rarely you can get psychosis also, this drug. Rufinamide, we don't use much, neurologists sometimes might use. Mood stabilizing properties in isolated cases, but we do not have much evidence to quote it. Lacosamide, many of your people use it, lacosamide. Isogabin and parapanel, euphoria at high doses. I think psychiatrists very rarely use. I use lacosamide for better reasons known to me. Phenobarbital, topiramate, vigabatrin. Vigabatrin was the first anti-epileptic drugs which was correlated with psychotic symptoms. That is called psychotogenic anti-epileptic in the MCQs. Vigabatrin was the first answer. Tiagabin, gabapentin, levetiracetam, most often used, but it produces maximum behavioral abnormality, irritability, depression, and very rarely psychosis. Sonisamide, a dosage, sometimes you can get psychotic symptoms, but usually depression, may have negative effects on the mood. Out of the anti-epileptics, if you just see, the worst effect is with the levetiracetam. Though levetiracetam is sometimes used in intractable bipolar disorders, only 14 case reports, the whole case report, but the dose used is very high, very rarely used, cost factor also important. If you just see the comparison with the valproate, with levetiracetam, valproate has got the least behavioral side effects. So suppose you get a person with seizure disorder, the behavioral manifestation, if you want to use a anti-epileptic, I think, depending upon the age, the gender, whether it's a reproductive age group, otherwise you will go for valproate group. There are seizurogenic antidepressants. Bupropion, Wellbutrin initially, sudden escalation can produce seizures. That is why it was withdrawn in between, then again came up for reason better known to you. I will not go into the history. Meprotilene, clomipramine, amoxicillin, nitroxazepine, because we had sindamil earlier, now it is not there. It can produce seizures. If SSRIs induce seizures, always rule out hyponatremia, especially SIADH, that might be the reason. Epilepsy Foundation Mood Disorder Initiative, they say you have to manage these people, stage 1 monotherapy with SSRI or CBT, and stage 2 monotherapy with a different agent as recommended. Stage 3 is monotherapy with the SSRI, TCA, venlafaxine, mirtazapine, or monoamine oxidase inhibitors. There is a rebirth of monoamine oxidase inhibitors. Now it's coming. And stage 4, as we usually do, a combination. Otherwise, then you can have stage 5, even intractable, this thing, you can give ECT, you can have neuromodulatory techniques, you can do, or you can have any DD, desperate DRs. What is DR? Desperate remedies, whatever you think best. Anxiety disorders related to seizures have been classified. Periictal can be preictal or postictal. That is the usual ictal fear. Whenever you get a patient as an aura, here with the anxiety symptoms, maybe that is originating from the peri-insular region. That you can even localize some of the symptoms. Indirectal classical anxiety disorders, but recently there are some specific anxiety disorders in epilepsy has been described. Anticipatory seizure anxiety, seizure phobia, epileptic social phobia, epileptic panic disorder. These are the new terms which have crept into. Iatrogenic, you can also even manufacture illnesses, that is addition of anti-epileptic drugs with negative anxiety properties, which I have already told you, or withdrawal of an anti-epileptic drugs with anxiolytic properties. That is understandable, I will come to that. Addition of anti-epileptic agent with negative anxiety properties are lamotrigine, levetiracetam, parapanil, topiramate, and sonisamide. So you have to be selective when you do it. So, or you withdrawal of an anti-epileptic agent with anxiolytic properties like pregabalin. Patient is on pregabalin, sudden withdrawal can induce this thing. Benzodiazepine, gabapentin, valproate. Valproate has got anxiolytic effect. The antidepressant effect is modest, valproate, but anti-manic effect is demonstrated well. If there is a reduced level of ongoing psychotropic drugs caused by the addition of enzyme-inducing anti-epileptic drugs, phenytoin and carbamazepine, they are inducers of NSAID, so the levels will be low. But what about then valproate? Valproate, majority of them is metabolized through the glucuronide pathway. A P450 system contributes only to 10 to 15%. And valproate is the NSAID, it's not inducing, but it's an inhibiting agent, unlike phenytoin and phenobarbital and carbamazepine. Post-surgically, all anxiety disorders are possible and intermittent increasing anxiety. Anterior temporal lobectomies have been associated with the remission of pre-surgical mood and anxiety disorders. Why? Because anterior paralimbic region is involved in most of the mood and anxiety symptoms. Risk factors, dysfunctional family dynamics, family history of psychiatric illnesses, older age, male sex, experience of auras in ictal fear, and poor seizure outcome, they dictate some of the risk factors which have come in the thing. There's a beautiful book, Psychiatric Complex Epilepsy article after epilepsy surgery, but where are the psychiatrists? This has come in Epilepsy and Behavior 2019, only in press. It will come in 20th, the thing, that is article before publication. That's why I put it press. The notes of default mode network, distortion in epilepsy, non-epileptic mood disorders and schizophrenia. You might be aware of all the networks, usually the central executive network, the salience network, the default mode network, etc. In epilepsy plus mood disorder schizophrenia, the classical regions involved are the precuneus and the posterior singular cortex. They are part of the default mode network stick. But suppose you get a mood disorder or even schizophrenic symptom, usually it is the medial prefrontal cortex. But inferior parietal lobes and nucleus accumbens dysfunction will dictate schizophreniform or schizophrenia-like symptoms. Now, focus will be on psychosis of epilepsy. Psychosis resembling a primary psychotic disorders is 6 to 12 times more likely in patients with epilepsy than in the general population. Seizure-related psychotic symptoms are ictal, postictal, and interictal, that everybody knows it. Pre-existing psychiatric disorders can be comorbid with seizure disorder. That's okay, we know that. Antipsychotics may lower seizure threshold in some of the antipsychotics. Some of the anticonvulsants also have been shown to worsen psychosis. How common is it? It's not that common. Prevalence of psychosis in temporal lobe epilepsy is 7%, interictal psychosis 5.2%, postictal psychosis 2%. This article I like, which has come in Epilepsy and Behavior 2018, they have put it in the bidirectional relationship. Psychosis before the onset of epilepsy, the risk ratio, and the psychosis soon after epilepsy formation. Beautifully put it. That means it is bidirectional. If you want to go into details, you read this article in Epilepsy and Behavior. Phenomenology, you have got ictal, postictal, interictal, and schizophrenia. For this, I think, how many minutes? Enough time. Ictal, it is very transient, very limited. You can get anxiety symptoms or a fear, which I have told you. sometimes some changes here, and even the epigastric region. Usually these are from the periangle area that happens. Postictal, there is a gap of 8 to 12 hours. Delusions commonly seen are grandiose, religious, and somatic. Visual auditory hallucination may be there, but insight will be preserved, and strong affective component, that is the thing, and clouding of consciousness may occur, but not that prominent, but amnesia for the events in some of the cases. Interictal, complete clear sensorium in interictal classically, mystical experiences. Suppose somebody has changed the religion suddenly. That's called the Diskutas series. Suddenly you say, I have become a Muslim now. But as soon as that's interictal, that's called Eskutas. Eskuta is a name. It's a series of papers. Mystical experiences, visual or auditory hallucination, but most important, clear sensorium, and negative symptoms less common, and premorbid personality usually okay. Schizophrenia, I need not to say that it's a neurodevelopmental disorders. Everybody knows about it. But I would like you to read the journal called Practical Neurology. I think to be a psychiatrist, you have to be an internist, you have to be a neurologist, and nowadays you have to be a legal expert. And very recently I used to say you have to be a radiologist, because that's called the psychoradiology. Last year the term has come. And fifthly, you have to be a statistician. And sixthly, you have to be an engineer in the atomic era. The majority of studies, this you need not worry about it, postictal. Risk factors, family history of psychosis or affective disorder, early age of onset of epilepsy, left temporal epileptogenic focus, hippocampal sclerosis, history of status epilepticus and the long duration, and history of febrile seizures. Febrile seizures, don't neglect, even if the history you have to be, you have to give important. Poorly controlled seizures. And postictal, almost the same, except that structural lesions. Interictal, focal epilepsy usually, anti-epileptic drugs, then the sum of the previous seizures, intellectual disability, family history of psychosis, these are the risk factors. What causes psychosis? This is the most important thing. Maybe kindling mechanism, which we usually talk. You usually get changes in neurotransmitters, especially the sensitivity of the postsynaptic dopamine receptors, increase in turnover of the GABA turnover, reduction in aspartate and glutamate. When we talk about the glutamate hypothesis, even schizophrenia, many people are confused. Schizophrenia is NMDA hypofunction, but non-NMDA hyperfunction. There's some confusion. And normally in axonal sprouting of the dentate granular cells, inflammation-induced, neuroinflammation induced, dysregulation of connexin gap junctions, that are called connexin and pannexin gap junction and hemichannels. You can go through, if you are interested in Journal of Neuroscience 2018 and current psychiatric report. Recent mechanisms described by glial hypothesis, hypoperfusion hypoxia hypothesis. This is a new term which has come last year. Neuroglial coagulonome, that is the thrombin receptor and coagulation pathways as major players. Don't worry, don't get confused, read the basics. Cortical dystenosis and acquired insults. So what happens basically? It is basically a dysfunctional connectivity between the dentate gyrus and the corpus ammonis area 3, that's CA3 region of hippocampus, relative to the induction of epilepsy and schizophrenia. There is a dysfunctional connectivity in the dentate gyrus and CA3 region. Apart from that, there is an ectopic mossy fiber projection that happens almost like an ectopic, you get it here. In the routine, usual development, here, oh sorry, oh my God, I think this is not good for me. This left side, mosaic fiber usual development, you see that the dendrite and CA3 regions, very difficult for me, man. That's called SL, that's called striatum lucidum. That's the usual pathway. But in mosaic fiber sprouting, that goes to two branches, superior, inferior branches, that are called striatum aureum. And those people who get psychosis, this happens. Instead of striatum lucidum, the superior and inferior bundle of striatum aureum comes, so they get the spark in between. That is the region. Glial hypothesis, there's epileptogenic hippocampus, astrogliosis, microgliosis, increase metallothioneins 1 and 2. That word, metallothionein 1 and 2, please remember, the reason is in temporal lobe epilepsy and major depression, metallothionein 1 and 2, they are decreased. But in psychosis, that one is increased. Similarly, increased immunoreactive area of glial fibrillary acid protein, GFAP, is increased in psychosis. And there's one thing called aquaporin. You know about aquaporin 1, 2, 3, 4 and everything. Aquaporin 4 is very important, especially when we discuss the cognition, etc. That changes, decrease is there in epilepsy with psychosis. There's the two-hit model of psychosis epilepsy. There's aberrant limbic activity and impaired frontal control. So reduced dopamine activity within the prefrontal cortices appears to underpin both epilepsy and schizophrenia. Prefrontal cortex means which side. If it is the dorsolateral prefrontal cortex, that's important, especially for working memory. If it is going to the medial orbitofrontal cortex, if it is towards the medial side, you will get depressive symptoms. If it is towards a little bit of the lateral side, you can get obsessive symptoms. If it touches upon the nucleus accumbens, you can get convulsive symptoms. These are all correlations. So epilepsy-related psychosis is immunity is a factor. Currently, you might be seeing many patients with NMDA receptor encephalitis. Autoimmune encephalitis, one of the varieties, NMDA encephalitis. We do have many variants of that. There's a new classificatory definition, classificatory diagnostic criteria for NMDA encephalitis. Recently it has come. There's a role for immunity, what happens, why they get psychosis. NMDA are hypofunction. It produces increased pyramidal firing. It increases inhibitory activity of nucleus accumbens with the globus pallidus medial portion. Decreases the inhibitory tone over the ventral tegmental area dopaminergic neurons and increased production of dopamine that produces psychosis. We can have the exploratory model. This is the simple way of putting it. I do have the figures with the diagrams and everything. I thought that it is so exhaustive, so I put in a symbol format. This is the simplest possible for me. Antipsychotics, will it produce seizures? Chlorpromazine, low risk if you use less than 1000 milligram. But if you hike up the dosage, more than 1000 milligram, there is a small chance of schizogenicity, but sudden escalation can produce more. Low to high risk of fluphenazine and perfenazine, very low. Low to high risk with haloperidol, many teachers say haloperidol will produce lower the schizotheral nonsense. It won't. Seizures have been reported, but no incidence is available for pimoside and thyroidazine. Dose related with clozapine. Clozapine is an anti-epileptic in lower dosage because it has got a limbic mechanism. But higher dosage, it has got a cortical mechanism that is epileptogenic. High risk with ANCIPS, even quetiapine also can produce. aripiprazole, risperidone, and suprazodone very low. No incidence is available for paliperidone, iloperidone. Why iloperidone? No reports. Iloperidone is nothing but risperidone in a new form. And acidapine, lurasidone, brexpiprazole, and cariprazine till date. Frank psychosis has been reported more frequently following the initiation of specific antiepileptic drugs, including phenytoin, sonizumide. It may not produce much weight gain, but it may produce psychosis. Topiramate can produce psychosis, but initial reports of topiramate in Germany, basically you can have cognitive abnormalities. But topiramate is known for your glaucoma, your fever, drug fever, everything, you know it. Okay, and even stones. Levetiracetam can produce severe irritability and depression. Psychosis could be a direct effect of anti-epileptic drug or associated with the concept of forced normalization phenomena of which is forced normalization. Landau's hypothesis, everything that you have to know. Although speculative, psychosis as a complication of administration of anti-epileptic drug may appear only in association with structural abnormalities and neurochemical dysfunction involving the limbic circuit. I think it is a basic fundamental thing that everybody who thinks about the neural circuitry will understand. Neuroimaging studies, we do have only 18 studies till date with people with epilepsy, and conflicting evidence of the volumetric change in the hippocampus and amygdala, a distributed structural pathology beyond the mesial temporal lobe, changes in the frontotemporal functional network activation. Psychosis with epilepsy is a disorder of brain networks. For the convenience, white matter disconnectivity. Thank you, sir. It is how many minutes more? 10 minutes. I'm finishing it. It's a disorder of brain networks. White matter disconnectivity, I will not discuss today because that is itself is another area. Significantly reduced gray matter volumes in the left posterior postcentral gyrus and left supramarginal gyrus. If I am an examiner to the students, I would have asked what is supramarginal gyrus. Here I will not ask. Pharmacological management algorithm, very simple. If there's a DSM-5 criteria with psychosis, clear consciousness, you have to always think any history of epilepsy, etc. If it is there, you have to assess it. If it is interictal, duration is more than 1 month, depending upon the severity of the psychotic symptom, you have to select an antipsychotic drugs. The preferable antipsychotic drugs will be avoid NSAID-inducing anti-epileptic drugs. Phenytoin, carbamazine, they are NSAID-inducing drug, which is the NSAID inhibiting drug, valproic acid. But valproate is metabolized to oxidative system only 10 to 15%. Otherwise, it is on glucuronide pathway. Check anti-epileptic adverse effect. Check interaction between anti-epileptic drug and psychotropic drugs, and check serum levels if appropriate. That selection, you are the best judge which is supposed to do it, but you have to be aware about the drug-drug interaction. I think time is up, and I have to say thank you very much. This is almost like a schizophrenic phenomena, and any questions, I am ready to answer. I mean, if I know.
Well, thank you very much, Dr. Imondas. Please join us here. He will be answering the questions. But before that, I will just ask one or two things, not from him, but from the audience. I am very encouraged to see many young psychiatrists here, some middle-aged psychiatrists also. So please, I am excluding the senior psychiatrists. How many of you, the young psychiatrists, deal with epilepsy? Can you raise your hands? Very few. Thank you. Not senior people, sir. not senior people, only anybody who has gray hair is a senior psychiatrist. So nobody with gray hair, not even salt and pepper, you know. So young psychiatrists once again, how many of you deal with epilepsy? Some of you do. And how many of you deal with the psychiatric comorbidities of epilepsy or have dealt in the recent past? Well, nearly the same number. Let me ask you, if you can be bold enough to share with us, what has been your preferred anti-epileptic drug for managing patients of epilepsy with psychiatric comorbidities? You can come on the floor, there are mics there, and share your experience with us or your comments with us. Young psychiatrists. This lady is bold enough, I believe, I don't know.
Sodium valproate.
Sodium valproate. Anybody else? Any particular reason why you have preferred sodium valproate?
Because sodium valproate works in the psychotic disorders also, the bipolar disorder, mood stabilizer. I mean, and antidepressant, if the antidepressant no working, then also we do. In
Okay.
psychosis also you can use.
Okay, that's excellent. Please take the seat. Anybody else among the young psychiatrists? And now it is open to the house. Anybody can answer. What is your preferred anti-epileptic while you are dealing with epilepsy and, let us say, psychosis?
I am Dr. Jagdish from Bangalore. There are two issues. One, today we are seeing pre-ictal, ictal, interictal and post-ictal psychosis associated with epilepsy. Now, the question is, neurologists are more interested only to treat that attack, not bothered about the consequences or the interictal or post-ictal or pre-ictal, etc. Now, is it a time for moving the management of epilepsy from neurology to psychiatry? That's the one thing. Second thing, valproate is the best medicine, sodium valproate is the best medicine, and we can consider carbamazepine as the next one because they can address most of the behavioral issues associated with all these phases of epilepsy.
Well, thank you very much. With just one small thing, I'm not too sure whether we will be able to shift the care to psychiatrists, but at least we should make a pitch for collaborative care. So the neurologist must take into account our own particular expertise and skills in managing such complex disorders. Please.
Unfortunately, the physicians are, neurologists are more preoccupied about levetiracetam, ignoring any other medicine, not reading about the complications and induced psychosis. More than 16% of patients who are on levetiracetam can develop associated psychological problems.
You have made a very good point, please. I would like to have some comments from first Dr. Gautam Saha and then the final comments from Dr. E. Mohandas.
I do agree with that neurologists are very much preoccupied with the neurological part. They don't bother about the psychiatric part. But I'm really happy to see the young psychiatrists, they are really interested to treat epilepsy. Because epilepsy is a domain we studied in our MD post-graduation level and we studied in detail. So we can take care of both the part, neurological and the psychological or behavioral part. So Dr. Jagdish what said, it is really, we should think in which domain it will be, number one. Number two, regarding management and drug treatment, it is definitely sodium valproate is already, my young friend explained why it is the first choice. But considering if it is a female patient, whether you think it, young female patient or history of PCOD, what are the contraindications we should keep in your mind, whether you go for carbamazepine or other anti-epileptic drug. That's it.
Thank you. Sir, you are...
As psychiatrists, I think we are at a loss now because many of the psychiatric condition on the lower side, pediatrician rob it, upper story Alzheimer's dementia, neurologist rob it, other conditions, knowingly or unknowingly, neurologists treat them, correctly or wrongly. We are blaming them. Why don't we, as psychiatrists, know about neurology? Why don't we have a skill-based training and let us manage these cases rather than we blame us? So we have to really empower ourselves managing this thing. We have to have a better educative material, one. Second, valproate as a common term, as a molecule, it is different. Sodium valproic acid is different. Sodium valproate, your 2:1 is different. And divalproics, that is 1:1 equimolar concentration. Only one suggestion, I have seen many psychiatrists also writing, suppose the patient is on sodium valproate 400 milligram, when you shift to the divalproics, they reduce it. It is the other way around. If it is 400 milligram, you have to make it 750 milligram divalproics, not the other way around. You have to increase it, divalproics, you have to put it 750. Same is true with the carbamazepine and oxcarbazepine. I will not discuss much on it. Will you prefer carbamazepine? Yes, as Jagdish said, it is good. Only problem is a enzyme-inducing drug. So if a patient is on antidepressant, it can really pump out the drugs. So you make it a relapse. But this is an enzyme inhibiting, but it may not produce much side effect because it really involves only 10 to 15% in the oxidative, that metabolic pathway. So not bad. But in the reproductive age group, there is a big problem you have to discuss because so-called hyperandrogenism, polycystic ovary disease. That is why this year, 2019 last, there are many articles come, are we over-prescribing valproate? But as psychiatrists, we have to rationalize, you have to rationalize why you pick this drug. It is up to you to prescribe any drug, but you have to have rationalized. Out of this wide spectrum, out of all these drugs, wide spectrum is for valproate currently. And it can be used for many of the secondary mania, secondary organ syndrome. And there are purposes, dementia with BPSD, valproate is very effective and many articles come. Not only that, even epigenetically, histone methylation, demethylation effect of this thing and neuroprotective, many articles have come on valproate. It's up to you to prescribe whichever, but you have to have a better understanding of drug-drug interaction and you have to explain why. And whichever symptom you have got in epilepsy, if you can explain why this symptom, why this anxiety, why this fear, why psychosis, if you can explain and if you can put a pathway for that, I think you will be better informed. That has to be the way forward for all of us. Thank you.
Sir, one thing, it is an observation that the psychiatrists are using much more divalproic acid than sodium valproate. And if you see the neurologist prescription, they are using sodium valproate much more than divalproic acid. Is there any rationale or it is just a practice habit?
No, there is no rationale. Basically, historically, valproic acid is a liquid, and in order to have a better stability and because of the lesser hygroscopic effect, you came with sodium valproate. Sodium valproate has to be given at least 3 times to 4 times daily, not twice daily. In between, there was indication. Then came the gastric irritation to reduce it, 2:1 preparation, got the chrono preparation. Then the US FDA approved is 1:1 divalproics with better bioavailability and better no fluctuations. And it's a better technique, which I don't want to describe much, and equally effective. But why neurologists don't do it, I don't think they don't want to go with the the time. That is the reason. Okay, all are same. Okay, thank you.
Sir,
I think I might as well add one thing. You see, what I have seen in my practice, migrainous epilepsy, I mean, they work very well because it covers migraine as well. So if we put them on valproate, it covers both migraine and epilepsy, in addition to all what we have discussed.
thank you very much, sir. Please.
Thank you, sir. I am Devasis Kunar from Burdwan. I have seen that we many a time are forced to use multiple drugs in psychiatry, and there are justifications for that. Not that it is very illogical or unscientific. And that is a situation where you need to be cautious, because most of the psychiatric patients, other than mood stabilizers like valproate and all, they have epileptogenic propensity. And if you are using a combination like clozapine and clomipramine, or fluoxetine and nortriptyline, these are some of the, or bupropion with any of the antipsychotic or antidepressant. So these are the situations where you really need to be cautious, and I think that we should keep in mind.
We agree with you. Dr. Mohandas did refer to those as the risk factors. So one has to be careful about it. Thank you very much, sir. Next, Dr. Anil, please.
I'm Dr. Anil Prabhakaran from Trivandrum. Thank you, sir. Nice talk. But listening to your talk, we get an impression that all the behavior, they have a neural substrate. Even the epilepsy and the behavior disturbances has a neural substrate. And you talked about the molecules manipulating this behavior into a right behavior. So, what is wrong with a neurologist? I would prefer to call them as a neuroscientist, addressing all these issues with finer molecules. Why are we psychiatrists afraid? Is it an existential anxiety of a psychiatrist who believes that his roles are being taken away? Taken away by science, sir. It's a neuroscience. And psychiatry and neurology should come under neuroscience, and we should do away with the existential anxiety the psychiatrists are having.
I respect your viewpoint. As always, I respect most of your viewpoints. I'll respect this one also. That's why I said we should have a collaborative model of care. And at the same time, I'll endorse what Dr. Mohandas said. We should hone our skills in basic neurology. So that will probably give us more confidence as well as legitimacy in dealing with such conditions which require essential skills in which we are better adapted than a neurologist. Okay. I will request now, Doctor, please, this is the last. No more questions. We have to wind up at 1:45.
Excuse me.
We are last. We are done with, sir.
What is the role of magnesium? You know, magnesium.
Magnesium. Okay, thank you, sir. We got it.
Yeah. Initially, people have told that magnesium valproate, especially the animal research, I think magnesium is supposed to be better macronutrient. But very few articles are coming advantages. There is a journal called Magnesium Research, for your information. And initially, when I launched the molecule for the sake, when I launched the molecule, I thought that it might have some advantage. There's nothing much now. Thank you.
So, Dr. Gautam Saha now winds up the session. No, sir.
Thank you, sir. Thank you. I think its time is over. We are running short of time. Thank you, Sanofi, for sponsoring the program. And thank you all the delegates for attending the program. Thank you all of you. I want to conclude this program now and over to organizer.
I would like to request Dr. Gautam Saha, sir, and Dr. Ajit Awasthi, sir, to honor Dr. E. Mohandas, sir. I would like to request Dr. O.P. Singh, sir, to honor our chairpersons, Dr. Gautam Saha, sir, and Dr. Ajit Awasthi, sir. there is a session going in next hall that is on telepsychiatry. So anybody wants to attend, they can attend. I would like to request for symposium Dr. Santosh Mulitkar, Dr. Subodh Dave, and Dr. Katie Levitt, ma'am. Please come on the stage. With our honorable chairpersons, Dr. Mrukesh Vaishnav, sir, and Manoj Rajagopala, sir. Please come on the stage. Excuse me.
The chairpersons for this session are Dr. Mrukesh Vaishnav and Dr. Manoj Rajagopal. The speakers are Dr. Santosh Mudolkar, Subodh Dave, and Dr. Kate Levitt. And the topic is Developing International Career in Psychiatry, Opportunities in the United Kingdom. टेबल नहीं टेबल चलेगा टेबल चलेगा टेबल चलेगा Yeah, sure. We'll give you a mic there also if you want.
No, that's fine. No. Hello. So this is a session about international career of psychiatry opportunities in UK. And thank you for the delegates. We have Kate Levitt from Royal College of Psychiatrists. She's a dean. And we have Mr. Dave, also from the Royal College. And we have got Santosh Madalkar, who is an associate registrar in Royal College, as well as BIPA president. So can I request Dr. Santosh Madalkar to start the session. He's going to talk about developing international career in psychiatry. And he has been supporting all the Indian doctors in UK through the BIPA. Thank you.
Thanks, Dr. Manoj Rajagopal, for introduction. It is my absolute pleasure to be here at ANCIPS 2020. British Indian Psychiatric Association is the largest diaspora organization in UK for psychiatrists, and we have a long working relationship with the International Psychiatric Society. And through discussions with IPS, we felt that there was a need to have a proper symposium on international careers in psychiatry and speak from the experts themselves. So I've got with me two colleagues, the extremely popular and flamboyant Dr. Kate Levitt, who has agreed to be part of this symposium, and Dr. Subodh Dave, who's worked tirelessly for the last several years for the cause of Indian trainees and international medical graduates, and has helped in improving the profile of BIPA. My role is to introduce the topic of international careers and see what the situation is in UK, so that delegates come to know about the pros and cons and make a decision whether that is the right thing for them. I have two roles. One is the BIPA president, and my second role is as associate registrar for the Royal College for membership engagement. This symposium is part of BIPA RC Psych IPS symposium. I'll just tell you a bit about my training. I trained in India. I did my MD in India, and I then went to UK and did my core psychiatry training at Charing Cross and Westminster Medical School, as it was called then, and did forensic psychiatry training. But before I went to UK, I had absolutely little information about how the system works in UK, what I need to do in terms of building my skills before I land there. I had not been to UK any time, and although I spoke English, I'd hardly spoken to anyone English, and forget taking a psychiatric history in English with the English patient. So from then on, the journey has been really quite interesting, and I'll just go through some of the things with you. I think now India is the global leader. The training which you have in India is suited for Indian conditions, Indian scenarios, but generally most people would like to have exposure to what is happening in the Western countries, what developments are taking place, because even in India, there are various layers of where you fit into professional practice, whether it is at a district level, whether it is at a taluka level or metropolitan cities, whether you're part of multi-specialty hospitals, you have your own unit. And I think a sound training which UK provides is, I think, an extremely good platform to have. But before you make that journey, it is important to reflect what your strengths are, what your priorities are, whether you're planning to go abroad for the long term or whether you want to learn specific skills and then come back and use those skills in India. What are your support networks if you leave the comfort of your own home? And then what support systems you have in UK, because everything you take for granted here, suddenly you'll realize that you'll have to probably travel for an hour or more to get a samosa, for example, or a masala dosa if you want that. And you will have to get used to fish and chips. It depends, of course, on which place you are, but it's important. And you might, for a few days, not find anyone who speaks Hindi, Marathi, Hindi, Gujarati, or whatever your language is, Kannada, Telugu, Malayalam, I don't know. And then I think it's really important because life in the first few months can be quite stressful when you're dislocated from your comfort social network. You also may want to think about what your plan B is. If this is something which is plan A, what if that doesn't work right? What would be your plan B? And I think that discussion, that dialogue, internal dialogue needs to happen when you are in India. So that is what we call as blue sky thinking. This is the Lincolnshire countryside. Just thought a nice picture. The first question to ask is why go abroad? And if you speak to people here, and I went to UK before the internet era, really. So a lot of knowledge was gathered in Bombay on what used to be termed there as katta. So a group discussion sitting with other colleagues, and you'd come to know, oh, how do you travel after you land at Heathrow? And someone would say, don't worry, you just have to take the Thames Link. And sitting in Bombay, I didn't know what Thames Link was and where it goes. I didn't even know that there is an underground network until someone told, you don't worry, there's good train facilities. All you have to do is ask someone and they will help you. That is what I did, but I also relied on close family friends who came to pick me up from Heathrow, otherwise I would be lost. But within 1 week, when I was in central London, I was able to give directions to 5 other Chinese visitors who asked for directions to me. But that is the Bombay training, I guess. So just sharing that experience with you. And once you do train in UK, world is your oyster. You can decide whether you want to stay in UK, go to US,
All those years back, the first option was US, then UK, and being the financial capital of the country, what we used to do was do all these calculations. Welcome, Dr. Mrugesh Vaishnav. Please come in. Yes. No problems, yeah. It's no problems. It's our absolute honor to have you here for the symposium. Thanks. So why UK? Well, we have a long history of training psychiatrists. The Royal College of Psychiatrists has been in existence for around 178 years, although under different names. And a lot of Indian psychiatrists historically have been trained in UK. That generation now has retired. This was the post-independence generation where the only postgraduate qualification which was offered was DPM, and it was based in UK. Before that cohort came back to India and started developing psychiatric departments in India where MD and DPMs started really. The training is standardized, of high quality. You'll be exposed to specialty training and also be aware of working with teams and mental health legislation and different environment. And I think as a progressive economy, largely growing population, I think exposure to what is happening in the West is always crucial part. You've done the basic training, and then if you need additional experience, then there could be opportunities in UK. I have to say that none of us are on a recruitment drive. We're just explaining what the situation is in UK in terms of training. This needs no introduction. Is everyone aware what this building is? Yeah, Buckingham Palace, okay, and the House of God, yeah. It's in the news a lot in the last few days for different reasons though. India House is quite close to this place. That is where historically all the decisions were taken about India. Anyway, that's the historical side of it. I'm just mentioning it because I'm just reading William Dalrymple's novel, actually, Anarchy, and he's mentioned such a lot about the Victoria Memorial and Fitzwilliam, which is here in Calcutta, really. So it's quite interesting that we're having this presentation here. So the options in UK, going back to the options, basically, do you want to go with exams or without exams? Do you want to do the specialist training? Do you want to do a service job? Are you interested in an attachment? Or would you like to be affiliated with an organization which has got extremely high standards in education and training, like the Royal College of Psychiatrists, because you can apply for international affiliateships. And this is something which we are working on in improving applications from international members. BIPA, we provide the support, pastoral support, mostly when trainees come to UK. We try to give them the space and also have the discussion regarding how best to integrate into the system in UK. We have regular meetings and CPD as well. Do you want to come over just to attend the International Congress? And any one of you who would like to come to UK to attend the Royal College International Congress, it's held this year in Edinburgh. And you're all welcome. And we've got an international members reception at RC Psych, IC. So that is another opportunity. If you would like to come for a BIPA conference, we're going to have BIPA annual conference on 6th and 7th of June in Birmingham. And again, you're more than welcome to attend that. But before you make the trip, I think there's certain things you have to do, because what you don't know sitting over here is that, and I'll tell you a story about what actually happens once you go abroad. In Bombay, the discussion used to be that, see, psychiatry is in huge demand abroad. And then you used to hear stories about a psychiatrist owning a private island in US, and if you go to US, then you own an island or something like that. And you have all these fantastic stories and myths. This is all before internet era. Obviously, there could be lots of myths in the media about life in UK, USA, and abroad as well. But that is a different story. What you need to do is get the basics right. So try to prepare a good CV, which the CV would be different how you prepare a CV in India compared to how you prepare for UK. You need to get the English language test, and it is not that easy. If there was one thing someone would have advised me before I went to UK was to listen to BBC. And I did read quite a lot of articles from English articles, but no one informed me that, see, that is something which you need to do. And if you listen to BBC, you're more likely to understand the different accents, how English is spoken in UK compared to not being there. The only posh English accent which I was aware of in Bombay when we had the crowd from South Bombay. But their accent used to be, we used to call them Sood, or the pseudo accents. And I think that is not similar to the accent which is spoken in different parts of UK. So in the East End will have the Cockney accent, then you have got a Manchester accent. The second consultant who I worked with just in suburban London, she was from Manchester, and she used to call everyone love. And I was really quite surprised why she's calling everyone love, because that has such a different connotation in Indian context. But you need to understand the accent. Now I work in Yorkshire, and the greeting is, "Hey up!" What do you mean by that? "Hey up!" "Hi up!" So I think they're different accents. So I think you need to get used to that. There are a few other things which are don'ts, whether you are going for an interview or whether you're speaking to someone from UK. Don't talk about money, and don't talk about politics. The two things which people spend most time talking about here, but socially they are inappropriate. Don't ask anyone how much they are earning. Don't ask who they support, which political party, because that would be end to the conversation. No one is going to share that information with you. But this is just my advice. You could do anything you want, really. So, but I'm just saying, see, those are the things when you initially meet, you have to be mindful. A very non-controversial thing is to talk about weather. Everyone in England likes to talk about weather because it is always changing. Everyone keeps on mourning. Mourning is quite therapeutic in UK. Here, if you're mourning, it becomes as if you're not doing well. You are just fed up. While there, it is used as a time to start some conversation which has no meaning, because no one really wants to know your business. But to have some social conversation is good. You read the book by Kate Williams, Watching the English. Excellent book about how you need to understand the English, how they think. Because most of us think in the Indian way and then translate everything when we speak, when we go to England. But the English think differently. And I think you need to understand how they think. A lot of it is said by not saying anything in England. While here, you say something comes to your mind, you immediately say something. You have a heated argument, it is considered normal in India. In UK, you really can't have an argument. Even a minor raise of voice, they will say it all went into a meltdown. And there'll be a huge uproar that so-and-so doctor, he came from abroad and he was actually raising his voice. You can't do that. The role of doctor is really quite different. There, patient is the boss. Everything is patient-centered. Patients are expert by experience. So you have to understand the power dynamics is really quite different when you go to UK. Any guesses? Who this is? Queen Victoria, yes. Where is it from? This is from the Kevin Gore Museum in Glasgow. She never came to India, but ruled India through the British Empire for several years. That is the legacy. Psychiatry league tables, I just mentioned, I think Dr. Lovett would be able to tell more about the psychiatric league tables and also all the things regarding choosing psychiatry as a career in her presentation. When you land in UK, we speak here English. We don't speak English because it's a combination of Hindi and English, mostly. Or it could be a combination of any of the South Indian languages and English. Accents and lingo are different. We don't really know or understand the English class system. So we need some icebreakers. 2 words, even if you don't remember anything in this presentation, remember 2 magic words, please and thank you. And you have to say that always. Don't take anything for granted. Please, please, and thank you, always. And then, well, you may want to change your dietary preferences. We have a combination of both. Either you can go for a curry. Curry, by the way, is quite popular on a Friday night. There are lots of Indian restaurants. Most of them are owned by Bangladeshi community. But any village, you'll have one Indian restaurant. But there are more and more of Indian restaurants by Indian people from Indian origin, really. I think I've mentioned the do's and don'ts. I think don'ts are the important thing, how to make a good, positive start when you speak to someone. Work environment is totally different. Here in India, you're the boss. Yesterday, there were so many people who came to senior psychiatrists and were touching their feet. UK, no one is going to come and touch your feet. Please don't expect that. No one would. Here, you call seniors sir. Sir, in UK, you refer to someone as sir only when they are knighted. So you need to understand those differences. Interviewing an English patient is quite, you need some training before you interview an English patient. Those of you who have been to English medium schools would have read Renan Martin, English grammar. That is good, but the colloquial English is quite different. For the first 2 weeks, I had 2 English friends who kept on talking about quid. And I was trying to find out what does this quid mean, until I realized it is the currency, money. So 2 quid, 5 quid, 2 quid to go to central London, 5 quid to go somewhere else. And I was thinking, what is this quid? I couldn't ask them directly. But so the colloquial language is quite different. I've talked about being part of the team. In India, because of the competition, you're always trained to shine, outsmart the other guy, say how you're the best person. While in UK, you have to be part of a peer group. So all of you sail together, and then you move through the exams. And you all share and reflect on the problems professionally.
Please limit, we have the limit of times.
Okay, thanks. MDT model, shall I just end there, really. Sorry to have taken a bit longer than anticipated. Thank you.
We have Dr. Subodh Dave, who is Associate Dean of Royal College and has been heavily involved with getting doctors to UK, from India to UK. He also helps with the MTI program. And so we have Dr. Subodh Dave now, next.
Thanks, Manoj. Okay. Thank you. This is okay. Thank you. It's a pleasure to be here. I think good introduction, Santosh. Just to say that English, a lot of Indian Pakistani doctors now in the UK, and so English is kind of becoming the norm now. So a lot of my team members fully understand English. I'm sure that can be said for the college as well, Kate. So I'm sure that if people come there, it won't be a complete novelty for them. I'm going to try and whiz through my slides. It's a good experience always for me to come here. And I just want to talk briefly that working in the UK, people will come for different reasons. I think when people like Santosh and myself, we went to the UK, I think it was kind of a one-way traffic. And Vinay is in the room, who's going to become the president of the college in Australia. And what we're seeing now is that there's a global migration of the medical workforce. So we're seeing two-way traffic, three-way traffic, and in fact, a multiple-way traffic. So people want to work globally. People want to be able to work in different jurisdictions. So we see people coming to the UK, then going to work in Singapore, then going to Australia, then going to Canada, and that will be the future. So I think the pattern of migration, the pattern of adjustment that's required is different. But what we need to make sure, wherever we go, wherever we work, that we are able to work safely and effectively. So just because you're going to the UK, now we all are very proud of the training we received in India. I certainly am very proud of the training I received in India. But we have to make sure that that training is able to deliver a very safe and effective service for your patients in the UK if you do move to the UK. So I'm going to try and briefly set the context for that. And then the second part, it has to be professionally and personally fulfilling for us as well. It's no point going to the UK if it's not doing those two jobs as well. And interestingly, over the last few years, I've met a good few people who are migrating to the UK for completely different reasons. So I've got a colleague who is in Gurgaon. They've got a young son who has asthma, and they want to move purely because for environmental reasons. They don't want to live in Delhi anymore. So I think people will have different reasons, and I think it's worth bearing in mind that not all migrants will have the same reasons. So I hope that I'll touch those various points along my talk. Just a brief thing, I think Professor Bhowmick, some of you in the room may know him. He has been my mentor for a very long time. He was meant to chair this session, and he's from Kolkata originally. So it's fitting that I'm here in Kolkata, but it's just a little memory for him, because he would have been chairing the session if he was here. So this is where I come from. Some of you, anyone from Mumbai here in the room? Okay, some people from Mumbai, great. So that's Grant Medical College, which is where I trained. And I know there are a lot of few people at ANCIPS from there. And this is where I work now. I've got a split job. So I do part clinical job, which is in Derbyshire, which is a very pretty part of England. And then I have my academic role at the University of Nottingham, which is also in the center of England. And then I've briefly been involved in developing a postgraduate training program in Zambia. And that again shows that we often forget certain parts of the world, South America and Africa, when we talk about global migration. But these continents are also going to be a part of the new movement. So coming to the National Health Service. Now, most people will have heard of the National Health Service. And for British people, it occupies a very special place in their hearts. And though Santosh said we don't talk politics, I think you mentioned the word NHS, and it arouses a national fervor, probably the same as cricket does in India. And you can see why. It's the largest employer, one of the largest employers in the world, so with over 1.5 million people. I think when I went to the UK, I remember being told that the NHS was the third largest employer after the Chinese Army and Indian Railways. And I checked yesterday, Indian Railways is 1.3 million, so NHS has overcome but 150,000 doctors. So, and you're a part of this very large family. And I think wherever you work in the country, if you're working a part of the NHS, you do feel a part of the family. It's a very similar way of working, and though there might be local differences, on the whole, the patterns of working are quite similar. And that in itself is a little bit of a challenge when you move from here, where you've seen very different ways of working in private practice, in working in a government hospital, in working in a regional small clinic or a small private hospital. Working in a setup that is broadly similar can be a bit of a challenge. I don't know if you all can see the slide very well. Apologies for the background in the middle section, but I think it's visible. So you can see this is a Commonwealth fund which compares the healthcare systems across the world and on 5 different domains. And if you look at the UK, it comes up number 1 in 3 of the domains and ranks first overall. Now, different systems have ranked it differently, so I won't say that this is the only way of ranking the healthcare system, but consistently, whichever way you rank it, UK's National Health Service comes up as one of the best healthcare systems in the world. There are other systems like the Bloomberg's ranking where it's a little bit lower down, but that's mainly because they look at the percentage spend of GDP. And I think one thing that the NHS is criticized for is that it doesn't spend enough. And that's changing, and so I feel that those other rankings will probably change as well. So that building is the Royal College of Psychiatrists, where all of us have a role. And when we talk about excellent healthcare in the National Health Service, I think the Royal College of Psychiatrists has a similar role in kind of safeguarding the standards of care that is provided to patients, so standard of psychiatric care, and the standard of psychiatric training. And so just as I've talked about NHS being an excellent place of the provision of healthcare, in terms of guarding the standards, the Royal College of Psychiatrists plays a big role in that and in training. So the other big difference that I consistently find when I speak to trainees who are coming from India, Pakistan, Egypt, Nigeria, we get trainees from about 190 countries in the world. So NHS attracts a very global workforce. And what they all say is that the level of community services is very, very extensive. So even when people move from very developed countries, even from the US or Canada, you find that the level of community provision is very, 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 very good. And that certainly is true for a service like mine. I work in an inner city area in Derby, and we have pretty much every team that I've listed on that slide, which means that you're really trying to work within the community, using the resources that exist in the community. Now, that is something that probably comes fairly naturally to people in India, but in the UK, it's been a little bit more systematized to make sure that everyone gets that level of care. And that is relevant because a lot of the times people compare healthcare in India and in the UK, but that's like comparing apples and pears. I think if you compare private healthcare in India, and if you have the money to afford it, it's very good. I think the question is that does the poorest man on the street, and I think we are in Calcutta where even now you must have seen people pulling a rickshaw by hand, can that person afford £1 million, 2 crore liver transplant? In the UK, everybody will get that free of cost. And that is the big difference. So I think when we compare healthcare systems, we have to think about, well, does it deliver to everyone? I think in my hospital in Grant Medical College, when they introduced a 10 rupee fee for the outpatients paper, that created a little bit of uproar. People started protesting because 10 rupees was too much for some people. It would have effectively blocked the entrance and accessibility of care for those people. So I think we have to bear that in mind, that when we compare, we have to think about, is it accessible to each and every person in the country or not? So there are 56 mental health trusts, and I think Santosh has touched upon this, so I won't go into detail about this. But broadly, these are the 3 things that all of us look for as patients. So, the Institute of Health Improvement, Harvard, they've all done international surveys looking at what do you want as a patient. And if you go to the doctor, you don't want your doctor to kill you. So that's the first thing. We all want to be safe. And I know we joke about it, but the reality is that a lot of people actually die during healthcare procedures. That is the reality. So I think we have to make sure the services are safe. And then you want it to be effective care so that you actually get better. And then thirdly, also that you are treated nicely and compassionately and with dignity and with respect. And those are the 3 principles that every trust is judged against continuously. So every trust will have to provide a report to a regulator providing evidence that they are providing services on those standards. And that also means that you as an individual practitioner are also judged on all those standards. So that is a regulatory requirement. And some people find that onerous, but if you think about it from a patient perspective, then you probably feel far safer going into hospital or going to see a doctor who is being monitored in that way. A lot of people ask me about research, that will I be able to do research if I move to the UK? The short answer is that it depends on what kind of research. Every trust that I mentioned will be involved in research. Some will be actually conducting and designing their own research. Others will be taking part in research that has been designed by someone else. But every trust will have some research. And a trust like mine, for example, we've contributed to some of the biggest trials across the country. And then on the other hand is Maudsley, which has generated millions of pounds in grant money for research. But there is a significant amount of funding for research available in the NHS. This is another body, so training is talked about a lot, and there's almost about £5 billion of money that's available annually to support education for doctors in the country. So that's, well, not doctors, healthcare staff, sorry, but a substantial amount of that is actually for doctors. And you find that doctors' training is quite well resourced. You have the time to go and train, and you also have additional support available if you need that. So when people have extra learning needs for whatever reason, that is available. So what do you need to come and work in the UK? The main thing that you need are these two documents. You need an appropriate visa, and then secondly, more fundamentally, you need GMC registration, so General Medical Council registration. Without those two things, you can't actually work in the UK. So Santosh touched upon this, that you can come in as an observer. Now that doesn't require a GMC registration. You can come and do a clinical attachment. So look it up. If you Google this clinical attachment, a guide for doctors, RC Psych, we published a document that explains in detail what would an attachment involve, what kind of things that you can hope to get from an attachment, how do you go about getting one. But essentially, no PLAB needed, no GMC registration needed, but you can only observe. You can't actually do any clinical work. You won't have direct patient contact in that sense. You'll only be observing. But it's good to gain experience in a specific area of psychiatry. So I've had some people who come from different parts of the world to gain expertise in perinatal psychiatry or child psychiatry, and it's worked quite well with them. And in fact, Commonwealth Fellowship is a program that runs specifically to encourage that, and that's a 3-month fellowship program. So again, you can Google that, and you'll get some information about that. But working in the doctorate, GMC registration. Now, each time I come, I'm always contacted by a few people who will say that, well, should I go to this program? Should I go to that program? This trust is offering me that. That trust is offering me that. I'll tell you one thing, that always try and get information from the key source. So if you're looking for GMC registration, go to the General Medical Council website and look that up. That's the thing. You don't need 10 other people to tell you what's there. If you have any doubts, clarifications needed, email them directly and they'll explain to you. You don't need to pay anyone anything. So if somebody's asking you for money for processing that information, then almost certainly it's some kind of a scam, okay? So GMC doesn't charge any money, the Royal College of Psychiatry doesn't charge any money to give you information. So that information will be available to you. Just email us directly or email the GMC and they'll tell you. And the same thing with visas. There's no way of short-circuiting that. They have certain rules and you have to follow them. And so if you need any clarification of the rules, email them and ask them, and that's what you'll get. Briefly, I think it's a simple process, is that if we've got enough doctors to work in the country, then we don't need to import them. But if there's a shortage, then we'll import them. That's the way it works. And that shortage occupation list is revised. Right now, psychiatry is a part of the shortage occupation list. But that can change. And historically, there have been periods when it has been, and sometimes it hasn't been. So that's one of the things. In terms of GMC registration, there are broadly 4 routes. There are some other minor routes. I won't go into all of them. But MRC Psych, which is probably the most popular route for people who have done postgraduate training in this country, because you can do the MRC Psych exam while you're sitting in India, and many people do that. Some people come to the UK and do an observer's post, but it's not mandatory. You can do the PLAB exam, and I know there are quite a few people who follow that route. There's MTI. Again, Google it, MTI RC Psych. If you Google that, we are going to be interviewing quite a few trainees next month. But there are a few other sponsors for the MTI-like scheme. And again, Google them. And if you need any clarification, you can still ask the college. And if we can't answer, we'll try and point you in the right direction. And the last one is CSER, which is a Certificate of Eligibility for Specialty Registration. And I know some trusts are trying to ensure that people who come to work for them would get that. But essentially, it's another way of getting a qualification to work in the UK. How are we doing for time, Manoj? Okay, all right. So I'll try and wind up in the next 2 minutes. So what I would say is the next slide is actually the most important one. So English language competence, I think all of you must be familiar. There are 2 tests, IELTS and OET. Look up OET if you don't know OET, because occupational English test, some of my colleagues tell me that they found it a little bit more relevant to their way of working and a little bit easier to negotiate. But that's, individuals may vary in that, but have a look at that at least. Have a look at this slide, because this is an important slide, because this is the slide that you need to, these are the competencies you need to demonstrate when you're coming to the UK. And I do feel that sometimes people haven't really absorbed all the competencies very well. And the first one is that make the care of your patient your first concern. And I think that in some ways is quite an important thing. And, you know, I think sometimes in the pursuit of academic psychiatry, we can try and absorb a journal and you might know all the academic findings in it, but you've forgotten how does that impact on the patient directly yourself. So that is the key thing. It's making the care of your patient is the first concern. Even if you've forgotten what's in the journal, that's okay. But how are you actually making sure that your patient is benefiting from the care you provide is the key. And then so on, you can see that a lot of them deal with treating the patient as individuals, respecting their dignity, being honest. All of that will follow. So I think have a look at these competencies and think of real examples where you feel that you have demonstrated those competencies. And they will be helpful either in an interview situation, if you're doing an MTI interview, or even in the CASC, if you're going to appear for the MRPsych exam. You'll find that these competencies will actually help you in terms of doing that. So people keep asking me how long does it need to prepare. I would say start early. Look at some resources. My university, we've done a freely available set of videos. Even if I say so myself, they're quite good. I think you'll find them very helpful for your CASC practice, but also generally for preparation of any kind of interviews that involve working in the UK or for an attachment in the UK. The college leaflets are fantastic, and I certainly recommend everyone to have a look at them. Even if you're never going to step foot in the UK, they're probably relevant. A lot of my friends and relatives ask for information, and I guide them towards that. They are available in multiple languages.
Sorry, Subodh, can we run?
Okay, so they're available in all the languages, so I would say look at that. And I think I'll leave you with that if you want to contact me. Thank you.
Thank you. That's a very informative session from Subodh. Now we have got Dr. Kate Lovett, our Dean for Royal College of Psychiatry, and she has been very much involved with international medical graduates and supporting, and she has been spearheading some of the things which Royal College has been doing for international graduates. Her keenness and enthusiasm can be seen because she was delayed in Mumbai for almost 5-6 hours, and then she lost her luggage. Still she was here and was there spearheading for the walk for the mental health. Thank you very much for coming all the way from UK, Dr. Kate Lovett.
Thank you, Manoj. But before I start, can I just check how long we've got? About 10, 15 minutes? 15 minutes, okay, fantastic. Because we have time for questions at the end. Maybe 1 or 2. Okay, that's lovely. Well, thank you ever so much and for that very warm welcome. I'm Kate Lovett. I'm the Dean of the Royal College of Psychiatrists, and it's an elected post. My term of office is 5 years, and basically I'm responsible, partly, I have two roles within the college. I'm a trustee of the charity, and I'll tell you a little bit about that, but I'm also the person who's responsible for training overall for all UK psychiatrists. This is me, Kate Lovett, and this is me getting ready to come to Kolkata. Very excited. This is my first ever trip to India. I can't believe that it's taken me so long in my life to actually manage to get here, because I've had the wonderful experience throughout my career in the NHS of having worked with many dear Indian colleagues. One of the wonderful things about having the privilege to train as a doctor is that you become part of a global team. And within my local team, I work with people from all around the globe, and I would really miss that. That's one of the things I really value. So this is the globe of the world turned on its head outside the London School of Economics, where my daughter was just getting her master's degree the other month, and we took a snap of me pointing out where Kolkata was. So thank you for your welcome to India. This was me on Tuesday, a few hours after I had come to Kolkata, walking with you in solidarity to raise the profile of mental health. And I understand there were over 2,000 people walking the streets of Kolkata and 700 school children. And what a fantastic welcome that was. And it's made me really reflect on the welcome we give to doctors who come to support us in the UK, who run our National Health Service. And I sometimes think that we're not very good at that. And I had such a warm welcome. And within a few hours, I was part of your community, eating a picnic in the park and feeling very welcomed. And this is me on Tuesday talking to some medical students. And I learned a lot about the recruitment challenges here. These were medical students from all 5 of the medical schools, medical colleges in Kolkata. And I was so impressed by the questions that they asked, really searching, intelligent, authentic questions, and a degree of freshness and honesty that quite often I think we've beaten out of our medical students in the UK by the time that they get to that stage. And this was at the Advanced Institute for Neuropsychiatry, and look at the cake that they made. On this occasion, I was able to have my cake and eat it, and it was very, very good. So you've already seen a slide from a slightly different angle for Subodh, the Royal College of Psychiatrists. This is where I spend a couple of days a week. But there's just a map of the UK. I work and live in the southwest of England, in that little sort of dog leg down at the bottom there. I'm one of 4 officers, and bring greetings from our president there on the left-hand side, Professor Wendy Byrne. And next to her is Adrian James, Dr. Adrian James, who's just been elected as our new president. So he will take up office in July, myself and our treasurer, Dr. Jan Falkowski. And I thought I'd just tell you a little bit about the college. So our purpose is to secure the best outcomes for people with mental illness, learning disabilities and developmental disorders by promoting excellence in mental health services, training outstanding psychiatrists, promoting quality and research, setting standards and being the voice of psychiatry. So we're very often called upon by government, by media, to talk about topical issues and to be involved in setting policy. And I know that the Indian Psychiatric Society plays a very similar role here. We have a number of objectives, and I'll skip over those. And fundamental to all the work that we do is our values. So our values are about having courage, about being brave and standing up to defend the rights of people with mental illness, very often who do not have much of a voice for themselves. We are about innovation, about trying to do things differently and better. Very much about respect, and we've done a lot of work on equality and diversity, and that continues to be something that we take care of. We have concerns about when that isn't as it should be. It's very much about working in partnership, about collaboration, about learning and excellence. I'm going to skip over some of this because actually it's not terribly interesting about the machinations of the college. But I suppose one of our principles in the international work we do is that it's got to be aligned to the values of the college and our overall strategy. And we must be invited. We don't want to go places and do stuff because we're about world domination or anything. We need to be invited as equal partners, and very much we have much to learn from each other, and I have learnt so much this week, just within a couple of days. So we have do a lot of international work. We have members of the Royal College of Psychiatrists throughout the world, including 285 members who are part of our South Asian division. And our international membership makes up about 17% of our total membership. So I'll just skip through UK psychiatrist journey, 5-year MBCHB or MBBS degree, and then on graduation people do 2 years of internship, foundation year 1 and year 2. And I think the difference that I've picked up in terms of our training is that psychiatry is a mandatory part of our undergraduate curriculum. Everybody does a psychiatry placement. We've been struggling with the fact that that's very variable throughout the UK, so some places do as short as 2 weeks up to 3 months, and we've been arguing that really that isn't good enough. It should be standardised, and that psychiatry should play, have a very significant part in the undergraduate curriculum. But I understand that very often in India people don't even have a mandatory placement. So internship, and then at that stage, people apply to go into training, do 3 years core training, in which they would be expected to pass the membership of the Royal College of Psychiatrists, and then elect to go into specialty training in one of 6 subspecialties in psychiatry. And at that stage, people are ready to apply for GMC specialist certification and would become a consultant psychiatrist. There are 6 specialties, they've all already been touched upon, and we work to a standardised curriculum. So everybody training in psychiatry in the UK is training on the same curriculum. Our current curriculum is just under review and will be implemented in 2021. Workforce is a massive issue for us, and we have lots of grand plans, lots of great aspirations and policy direction, and actually for some fairly reasonable government funding. Mental health is becoming much higher profile. People are talking about it, and patients are demanding better services. But we have a workforce shortage, and that just sort of demonstrates some of the policy stuff that we're trying to influence, some of the media work, and that was me on a television program. Ironically, has just announced that it's going to be shelved this morning, this Victoria Derbyshire show, which is actually a very important daytime television sort of political commentary programme. It's a shame. They've been very good at covering mental health topics. So I'm going to tell you about our medical training initiative. This is me in the antiquarian room at the college. This is our sort of little library with our old books. And these are some of the people who have been appointed to our MTI scheme. The MTI scheme is a scheme whereby high-flying, and I have to say this, the calibre of the doctors who come to the UK to do this scheme is hugely impressive. I interview every year for this, and it's one of the great privileges. We interview by Skype, and we spend, it's now I think up to 3 days, travelling around the world by Skype. We can be in Nigeria 1 minute, in India the next minute, in Egypt, and it's fascinating. You see people in their working environment. We do an interview over Skype. So it's a scheme whereby people get a training visa, a Tier 5 visa for up to 2 years, and posts are distributed throughout the country. They're approved by deaneries and the Academy of Medical Royal Colleges, and I personally have to sign the sponsorships forms. IELTS score, we've already talked about that, but you need to get a score of at least 7 in every section and 7.5 overall. We interview the candidates, as I've said, and there's a comprehensive application form. And what I'd say is that if anybody's interested in that, for this year, to start in August 2020, the closing date is the 2nd of February. So there is time still to apply, and I'm sure that we will be around probably at the back of the hall for a little while if people want to talk more. But I would direct you to the college website, where there is a lot of information about it. The good thing about the MTI scheme is it's very much designed to help complement people's training to fill in gaps. So we very often get experienced doctors, for example, who come from a country where there is no child and adolescent training program, but they come to the UK because they realise that there's a need, there's a gap in their training and knowledge, and they deliberately come to gain knowledge to take home again. So it's designed to avoid brain drain and with the idea of people going back to their home country, having gained good experience, which is going to help them meet the needs of their local country. Last year we had 98 applications and we approved 56 candidates. We have up to 80 places available, and people come from all around the world. So as I said, the deadline for applications is the 2nd of February, and there's more information on the college website. There we go. So examinations, I'll just very, very quickly touch on that. Have I got a couple of minutes? Yeah. Examinations are important, whatever part of the world you come from. This is a restaurant I went to in China, which says, it's called, "If you eat here, you will pass your exams." If only that were true. The membership exam is our postgraduate medical exam. There are 3 bits to it. There are 2 theory papers, paper A and paper B, and then our clinical examination, the CASC. The first one, paper A, is about scientific knowledge. The second paper is clinical topics and critical appraisal. This is where we sit the exams in Sheffield for UK candidates, and probably for most Indian psychiatrists sitting the clinical would elect to come to Sheffield. But you can sit the theory papers in 4 centres in the UK, and the centres there, Dublin, Malta, Oman, India, Singapore and Hong Kong. And at the moment our clinical exam centres are in Sheffield in the UK, Hong Kong and Singapore. And people are very keen to know, are we going to open a clinical exam centre in India? I've been told not to promise anything on my trip here, but for me it would make utter sense to be developing a strategy towards that, because we have so many people who sit the written paper, and I think it's unfair to make people travel to Sheffield and put them at a disadvantage in sitting a clinical exam. So it's something I'm keen to support, but I'm making no promises. Okay, I'm going to click through this because we're really out of time. The CASC exam is a tricky exam, the clinical exam. There are 5 history stations, 5 examination stations, and 6 management stations, and all stations assess communication. And what I'd say to anybody thinking of sitting it is to practice, to find somebody who's got through the exam and really get them to give you honest feedback, to observe you interviewing patients and tell them to be honest. We're often too polite, aren't we? We kind of like to give nice feedback, but very often what people need is really good, critical yet supportive feedback that's going to maximise their chances of passing. So I'm going to stop there and say thank you very much. Those are our contact details. For more details on the MTI scheme, it's mti@rcsite.ac.uk. We have a lovely film which I'm not going to show you in the interests of time, but again, please look at our Choose Psychiatry website. And I just want to say thank you for the welcome, and thank you all for all the work you do. I've been so impressed at how hard everybody's working to make a real difference, and you do make a difference wherever you end up in the world. So thank you for that. And I think, have we got a couple of minutes for questions?
Thank you for providing information. Professor Lovett, this year I have recommended at least more than 20 persons for MTI from our country, and still more people are asking for the recommendations. So you will have more applications from India. Now, any question? Question to any of the panelists is open.
Anyway, the doctors are around for the next, say, 2 days. So you can contact us. Any of us, we are all from UK, and we have got, say, Dr. Bamra, Dr. Mukherjee, Sujoy Mukherjee, and many of the doctors from UK. So please do contact us and approach us. We are all happy to help us.
See, on Dr. Rajgopal, formally, I would like to thank Dr. Mrugesh Vaishnav and Professor P.K. Dalal both from IPS, on behalf of the British Indian Psychiatric Association, for allowing us to come and speak to you. And it is an absolute honor to be here in India because we are sharing information and we work together, and thanks a lot for your support. And particularly Dr. Kate Levitt, who's traveled all the way. Manoj, in fact, she spent 14 hours at Bombay airport with no luggage. And then being able to come and do the walk the following morning was absolutely outstanding. So thanks a lot, everyone, for your patience and for listening to us. Thanks a lot. Thank you.
Thank you very much. With this, the session is closed, and over to organizers.
I'm just requesting our chairpersons to facilitate our speakers. I'm requesting our speakers to honor our chairpersons with the memento and the certificates.
Thank you so much. We have an half an hour, 45 minutes gap now. Our next session starts at 3:45. Dr. Jeffrey Gala.